Okay, so this recording is in adult medical nursing. It is basically a continuation of the lecture that was offered in class looking at peptic ulcer disease. So this particular recording will run through the pathophysiology of peptic ulcer disease all the way through to the management of peptic ulcer disease. So to begin, I'm going to just run through the pathophysiology using this particular diagram here, and so that it is easier for students to follow. So the principal thing in the pathophysiology of peptic ulcer disease is really an imbalance between the gastroprotective factors and the mucosal injurious factors, or those factors that cause harm or injury to the mucosa. So in terms of the pathogenesis, what really causes the disease, as was discussed in class, it can be that there's an infection with H. pylori, which is a gram-negative bacteria. Remember, we had talked about this gram-negative bacteria embedding itself into the mucosa using its flagella, and once it is there, it will secrete urease that will protect it from the low pH of the stomach. And then it begins to produce cytokines. This is what this diagram indicates as toxin release. So it will produce some cytokines rather. These cytokines will stimulate an inflammatory response. That inflammatory response inhibits the detection of protons in the gastric antrum, leading to overproduction of acids. Now, if the gastric protective factors at this point are intact, even in the presence of H. pylori, know that H. pylori will not be able to establish or to cause peptic ulcers as long as the protective factors are strong. Then if this problem is developing due to NSAID overuse, for example, aspirin or other antiplatelet agents, these NSAIDs, remember we said they block the cyclooxygenase 1 enzyme. When they block this enzyme is responsible for production of prostaglandins. And remember, we said that prostaglandins are important for promoting the production of bicarbonates, they promote the secretion of mucus, and they also increase blood flow to the epithelium, to the lining of the stomach, so that it repairs easily. But when NSAIDs block the cyclooxygenase 1 enzyme, this will lead to decreased prostaglandins. Decreased prostaglandins will lead to increased production of protons. They will lead to decreased gastric mucus production, and of course there will also be a reduction in bicarbonate production and a reduction in blood flow to the epithelia. So this puts the epithelia at risk for becoming ulcerated. NSAIDs, remember we said most of them they are weak acids, so their presence in the mucosa is able to directly irritate the cells of the mucosa, leading to injury and ulceration. Mucosa, in the case of Zollinger-Ellison syndrome, where you have increased acid secretion due to a gastrin-producing tumor. Remember, we said this gastrin-producing tumor can occur in the pancreas, it can occur in various parts of the body, and the principal thing is this gastrin-producing tumor increases the production of gastrin. Gastrin ultimately increases the production of protons. So stress in ICU settings, in Crohn's disease, also in cancers, for example, adenocarcinoma, squamous cell carcinoma, and lymphomas, all these reduce blood flow to the mucosa, leading to increased risk for ulceration. Now, we said the principal mechanism is that there's an imbalance between the protective and the injurious factors, or the factors that can damage the mucosa, which we had talked about. So in the gastroprotective factors, we described what these are: mucus, blood flow, epithelial cells, prostaglandins. Then we also talked about these injurious substances or hostile factors, which include acids, okay, increased gastrin, histamine stimulation of the parietal cells, gastrin, histamine, and acetylcholine. Those three had been drawn on a diagram. If you do recall, those increase acid production, but also toxins. So whenever there is more of the injurious substances or more of these hostile factors, more than the gastroprotective factors, then erosion of the mucosa will occur. When there is erosion of the mucosa, what will happen is that the erosion may proceed into the blood vessels. When this happens, they'll be bleeding into the stomach. So blood is going to be passed through the GI tract into the stomach. It will get oxidized by the hydrochloric acid and digestive enzymes. It is going then to be passed down into the feces as melena. So the feces, the stool, will appear black, tarry, and it will be foul smelling. If blood gets oxidized by hydrochloric acid, but instead of moving downwards to towards the anus, it instead goes, it is vomited perhaps through the mouth. What you see is coffee ground emesis. The vomitus will appear as if it is having some black coffee grounds. Those coffee grounds or those substances appearing like coffee grounds really are blood that is oxidized coming from the bleeding ulcers. If bleeding occurs into the esophagus, maybe due to an esophageal ulcer, a patient will have hematemesis where they're going to be vomiting blood. Then irritation of somatic innervation, that is thoracic vertebrae 5 to thoracic 8, will lead to dyspepsia, that is indigestion. Patients will also experience epigastric pain as well as nausea. Okay. So these we had discussed earlier, the mucosal defenses and also the hostile factors. We also discussed the NSAIDs, and I have just run through the NSAIDs, also the Zollinger-Ellison syndrome. And a reminder is that patients can also suffer from what is called stress ulcers. Now, we're saying stress ulcer is the term that is given to the acute mucosal ulceration of the duodenal or gastric area that occurs after physiologically stressful events such as burns, shock, severe sepsis, and multiple organ traumas. So these ulcers, which are clinically different from peptic ulcer, they are more common in ventilator-dependent patients after trauma or after surgery. And we had said that when an endoscopy is done, within 24 hours of the trauma or the surgery, what you'll see is that there'll be erosions of the wall. And by 12 hours, by 72 hours, there will be multiple gastric erosions that will be observed. So this is a typical sign of the stress ulcers. As the stressful condition continues, the ulcer spreads. When the patient recovers, the lesions are reversed. So when this phenomenon is observed, then you know that really these were stress ulcers. Now, actual cause of mucosal ulceration in stress ulcers is unclear, as was indicated earlier, but the mechanism has been associated with shock, for example. If there is shock where there is inadequate tissue perfusion, there is inadequate blood flow to the mucosa of the intestines, this will lead to decreased mucosal blood flow and to reflux of duodenal contents into the stomach. Decreased blood flow to the stomach, remember, is going to inhibit repair of the stomach, making it more susceptible to ulceration. Then in addition, large quantities of pepsin are released in stressful situations. Pepsin is able to break down proteins, including those found in the mucosa, and that will lead to ulceration. Then the combination of ischemia, acid, and pepsin creates an ideal climate for ulceration. Now, stress ulcer should be distinguished from Cushing's ulcers and Curling's ulcers, which are the two other types of gastric ulcers. So Cushing's ulcers, these are common in patients that have head injury and brain trauma, okay? They are common in patients with brain injury and with head injury and brain trauma. They may occur in the esophagus, stomach, or duodenum, and are usually deeper and more penetrating than stress ulcer. So this is typical of those that suffer head injuries. They'll develop Cushing's ulcers. Then Kerling's ulcers. These are frequently observed about 72 hours after extensive burns and involves the antrum, that lower portion of the stomach, the terminal one, the antrum of the stomach or the duodenum. So Kerling's associated with burns, Cushing's associated with head injury. What then are the signs and symptoms, the clinical manifestations of peptic ulcer disease? Number one, there will be epigastric pain. This is pain in the epigastric region, just below the xiphi sternum. It is worse just after eating as acid increases with gastric ulcers. So in patients that have gastric ulcers, what you see is that the pain will become worse just after eating. Maybe 20 minutes after a meal, you find that the pain worsens because the ulcer is in the stomach. It is a gastric ulcer. So even as the food sits or passes through the ulcer, it causes a lot of pain. Then for duodenal ulcers, note that the pain is worse when the stomach is empty. This kind of pain in duodenal ulcers, remember that the ulcers are in the duodenum, meaning when the stomach is full and there's a reduced secretion of acids into the duodenum, then duodenal ulcers will not cause so much pain. But when the stomach is empty, as the food now moves to the duodenum, that is when the patient will experience pain. They may awaken during the night due to pain. Weight loss, okay, or weight changes. The weight changes differ. In gastric ulcers, patients will lose weight. Why? Because the ulcer is in the stomach. And when the patient eats, they experience pain. So patients with gastric ulcers tend to feed less. Whereas in duodenal ulcers, you may see weight gain. Why? Because the pain of duodenal ulcer is oftentimes relieved by eating. When a patient eats, the pain reduces, so they tend to gain weight if they have duodenal ulcers. The pain is worse when the stomach is empty and it is relieved after eating, so they'll gain weight. Another set of symptoms is bleeding from the ulcers. So remember we said if the bleeding occurs into the esophagus, then a patient will have hematemesis. They'll be vomiting blood. Okay, so for vomiting blood, vomiting bloody fluid, which may be red or maroon in color, it is more likely with gastric ulcer, but also with esophageal ulcers. Then coffee ground emesis, this is partially digested blood. You may see this in gastric ulcers, and where I had talked about this, where the patient passes a vomitus that has what looks like coffee grounds. Then melina, sorry, it's supposed to be melina, M-A. Melina, this is taris too. It means that the blood has moved from the stomach, it's been oxidized in there and then passed all the way down through the intestines and out through the anus, and it will appear black and tarry and it will be foul smelling. This is common with duodenal ulcers, okay? Other signs and symptoms are those relating to perforation of the ulcers. If these ulcers perforate, if they excavate the mucosa so much, they pass the muscularis and begin to erode blood vessels, that is perforation. What you see is there will be sudden sharp pain in the abdomen. Then the abdomen becomes tender. When you apply some pressure on this patient's abdomen, they'll feel pain. The abdomen might become rigid, and we call that a board-like abdomen. The abdomen becomes rigid, the muscles tense because of the spasms that will occur due to the severe pain. The knee chest position often will reduce pain. because knee chest position, when the patient moves the knees or the thighs towards the abdomen, as if, how may I describe it? If someone is squatting, you move the thighs towards the abdomen. That movement reduces the chest, the abdominal pains slightly because it causes the abdominal muscles to relax. Hypovolemia is another clinical manifestation of perforation. It means these ulcers are now perforated. The mucosa is eroded, and even the blood vessels are now damaged. They are bleeding. Some specific clinical manifestations for gastric ulcers: you have burning or gaseous pressure in high left epigastrium and back upper abdomen. So the pain in gastric ulcers, those that occur in the stomach, often is described as a burning kind of pain or gaseous pressure. Patients with these ulcers often actually belch a lot. They complain of having too much gases. This pain is in the epigastrium and it may radiate to the back as well as the upper abdomen. Then the pain occurs 1 to 2 hours after meals, meaning not so far after eating. Then the pain increases. Patients may also experience occasional nausea and vomiting due to the severe irritation of the stomach lining. Then they may experience weight loss because they tend to eat less because the pain is worsened after meals. Then hematemesis, that is vomiting blood. What about duodenal ulcers? Duodenal ulcers may also present with pain that is described as burning, cramping, or pressure-like pain across the mid-epigastrium and upper abdomen. This one may also radiate to the back with posterior ulcers of the duodenum. Now, note that pain occurs 2 to 4 hours, which is much later. In gastric ulcers, we said 1 to 2 hours, but with this one, the pain will occur 2 to 4 hours after meals and mid-morning, also in the afternoon, and in the middle of the night, patients will have periodic and episodic pain. So 4 hours after one has eaten, the pain worsens. When they eat, they get some relief for the first 1 to 2 hours. Thereafter, again, the pain resumes. That is typical of duodenal ulcers. Then patients may also have occasional nausea and vomiting. And with duodenal ulcers, they'll have melena. Instead of hematemesis or instead of passing coffee ground emesis, they'll have melena because the blood will pass downwards from the duodenum downwards to the rectum and it will be passed in feces. The feces will be black, tarry, and foul smelling. So if I ask a question, in which type of ulcer is melena common? Then I put duodenal ulcer, I put gastric ulcer, I put esophageal ulcers, I even put maybe Meckel's diverticulum. So the melena is more common in duodenal ulcer. Patients who also present with dyspepsia, including belching, bloating, fatty food intolerance, and weight gain in duodenal ulcers. So very important, you should be able to compare and contrast gastric and duodenal ulcers. Now, what investigations should be done in peptic ulcer disease? So history taking should involve assessment of the abdominal pain to determine its location, timing, and severity of this pain. About blood group, so you need to ask about the blood group, or before I go to the blood group, why are we asking about this pain, the location, and the timing? Remember that duodenal ulcer it occurs a little bit further from meals, so 2 to 4 hours after meals, whereas gastric ulcers will occur 1 to 2 hours after meals. Okay, so that helps you, that timing. Duodenal ulcers will worsen in the night and the patient might be awakened with pain. That is a sign. Then about blood groups, remember what we said about various blood groups and their risk for peptic ulcer diseases. So you need to know the patient's blood group. ask about lifestyle and health history, as well as intake of aspirin and other NSAIDs, which are a risk factor for peptic ulcer disease. Then in your physical examination, you would want to palpate the abdomen for tenderness, which is usually present in the upper epigastrium left of the midline. Then endoscopy is a key diagnostic procedure. It can visualize and identify inflammatory changes. It is able to show ulcers and lesions. So this is gastroscopy plus duodenoscopy to observe the mucosa, where a fibro-optic instrument is passed through the mouth all the way through the esophagus into the stomach, and it may also be pushed into the duodenum so that the images are being shown on the screen and the expert is able to identify the presence of inflammation or ulcers. Serological tests. So blood can be collected to detect antibodies to Helicobacter pylori. So if there are antibodies against H. pylori present, it means this patient is positive for H. pylori and they'll need to be treated with antibiotics. Then biopsies may be done for gastric ulcers to diagnose benign status. If the gastric ulcers have been present for a long time and you're suspecting that they're turning into maybe gastric carcinoma, a biopsy, a small tissue will be taken from the ulcerated area, and they need to be examined to see whether it is showing malignant changes. I should mention, first of all, also regarding the H. pylori test, that other H. pylori tests involve collecting stool. So it's not just the serological test. The serological test looks for antibodies, whereas the one in the stool, you are looking for the antigens for the Helicobacter pylori. So take note of that. Spatial radiology will include barium meal, which is done to visualize the ulcer after the patient has taken the barium. So the barium is going to line the mucosa of the stomach and you'll be able to see where the ulceration is. Stool examination is able to show the presence of occult blood or fresh blood in the stool, which may be a sign of bleeding from the gut. Remember the melena that we talked about. Then gastric secretory analysis. This procedure is done using fluids that are suctioned directly from the stomach and the duodenum to measure the amount of acid. So this procedure is done only if ulcers are severe or recurrent, or if surgery is scheduled, so that you are able to see how much acid is being produced. Treatment of peptic ulcer. So the aim is to relieve pain, to protect the mucosal barrier so that you promote healing, to prevent complications and recurrence, then also to eradicate H. pylori infection. So the above aims can also be achieved through the use of drugs such as antacids, H2 receptor antagonists, proton pump inhibitors, and analgesia, as well as antibiotics. We'll look at the drugs in a little bit more detail later. But very important, we need to advise the patient to change their lifestyle. What lifestyle modifications should they institute? They need to avoid taking large meals because large meals will irritate the stomach and will worsen the condition. They should avoid acid-containing foods, for example, citrus fruits, tomato. They should avoid alcohol. Remember, I said alcohol interferes with the bicarbonate. Caffeine lowers the pressure at the lower esophageal sphincter. So reflux becomes more common. Caffeine may also directly irritate the mucosa of the stomach. Chocolates, onions, garlic, peppermint, all these spices foods should be avoided. They need to decrease fat intake because it worsens the condition. They need to avoid lying down within 3 to 4 hours after meals. Such patients really, especially to prevent reflux of gastric contents into the esophagus, they should eat at least 4 hours before they go to bed. Alternatively, they can also elevate the head end of the bed 4 to 8 inches so as to prevent reflux of foods into the esophagus. Then they need to avoid medications that may potentiate gastroesophageal reflux disease. Calcium channel blockers, for example, will make gastroesophageal reflux disease worse. Alpha agonists, these are used in the treatment of hypertension, okay? Theophylline derivatives, theophylline itself, which is used in treatment of asthma, nitrates, sedatives, and of course NSAIDs. These should be avoided because they may be a risk factor for, or they may worsen the condition. They should avoid clothing that is tight around the waist because it causes increased reflux into the esophagus. Lose weight. Patients should endeavor to shed some weight. That helps, especially with gastroesophageal reflux or with the esophageal ulcers. They should stop smoking because that worsens the condition, as we discussed earlier. In terms of dietary modifications, we've talked about, I think, most of these factors. I just want to emphasize that they should eat slowly and chew the food thoroughly to prevent over distension and reflux. Bedtime snacking may promote nighttime secretion and should be avoided. Those midnight snacks that people take, they should be avoided because they'll increase the production of hydrochloric acid in the night. Okay, the patient should limit the use of all these foods here, which we've already talked about. Surgical interventions, really you cover them in greater detail in your surgery, but vagotomy can be done where there's resection of the vagus nerve to stop the stimulation by hydrochloric acid. Also, total gastrectomy can be done where there's the removal of the stomach in case these ulcers are extensive. Perhaps they've actually caused cancer to develop. Subtotal gastrectomy, this is removal of part of the stomach, usually where the ulcers are located, and also removal of the acid secreting mucosa. Then anastomosis or connection will be done between the esophagus and the stomach. Pyloroplasty, this one enlarges the pylorus by removing the sphincter so that there can be no stasis of acid-containing foods at the antrum of the stomach, the pylorus rather, the exit. Treatments, the drugs, very important for adult medical nursing. Note that we use what is called triple therapy regimens against Helicobacter pylori. The target is to give antibiotics that will eradicate the H. pylori and then give a proton pump inhibitor. Remember, we said the parietal cell pumps out protons that will combine with the chloride ions to form hydrochloric acid. So if we can block the proton pump using drugs, then we are able to treat peptic ulcers. So there's a 14-day regimen, which can include omeprazole. Omeprazole is a proton pump inhibitor, 20 milligrams per oral twice a day, or we can use esomeprazole if there's no omeprazole, 40 milligrams per oral 4 times a day. Then we add 2 antibiotics. So triple therapy basically involves giving 2 antibiotics and 1 proton pump inhibitor. That's what makes it triple. 2 antibiotics and 1 proton pump inhibitor. So in this regimen, we're using clarithromycin and amoxicillin as the antibiotics. Alternatives are all these others that can be used. This one is quite common where you use maybe omeprazole plus clarithromycin plus metronidazole. You will hear of combinations, for example, Pylokit. I think Pylokit contains lansoprazole, which is a proton pump inhibitor. Then there's also tinidazole, which is an antibiotic, an imidazole derivative belonging to the same group with metronidazole. And then it also has clarithromycin. So this is an important one. Please remember it. Okay, so that's Pylokit there. I've already talked about it. So therapy is for 7 days, but it can be continued up to 21 days depending on response. If after 7 days, the H. pylori is not eradicated, then it will be continued for up to 21 days. Then here I should mention that in addition to the proton pump inhibitors, for immediate relief, we also use antacids such as magnesium trisilicate 3 to 4 times daily to just reduce gastric acidity. There are also all those other antacid suspensions that can be taken. For example, Ulcer gel, those should be taken together with the eradication of H. pylori using these antibiotics. Another set of drugs, we have the H2 receptor antagonists. So basically what I've talked about, this is the hallmark where you use 2 antibiotics and a proton pump inhibitor. But I believe in your pharmacology, you've learned about other ulcer healing drugs, which I won't go through in detail. The H2 receptor antagonists, these ones block the histamine 2 receptors at the parietal cells. Remember that histamine stimulates production of hydrochloric acid. So when we give drugs that block the H2 receptors at the parietal cells, then that will reduce production of the protons. So examples include cimetidine, okay, we have ranitidine, okay, and then we have another class of drugs which are the proton pump inhibitors that I've already talked about. So in your own time now, I want you to take time. These, obviously, you've done this in your pharmacology, but the nursing management, largely it focuses a lot on the health education that we give to patients. But now this is problem analysis, where we use a nursing model. So in this case, we are using Orem's theory of nursing to conduct a problem analysis. So what we just do is that we go to all the universal needs and see whether the patient has a problem with meeting all the 8 universal needs. So under sufficient intake of food, we are saying patient may have imbalanced nutrition, less than body requirement related to fear of pain after taking foods. That is if the patient has gastric ulcers. Patients may experience nausea and vomiting related to gastric or esophageal irritation. Then in duodenal ulcers, patient has risk for imbalanced nutrition greater than body requirement related to relief of pain after eating. So you've analyzed this particular need. You've indicated the problems that the patient will have with meeting this need. So I just want to guide you that this is how you go about writing a problem analysis. You pick the next need according to Orem's theory, which is sufficient eliminative function. Patient may have constipation or diarrhea due to the side effects of drugs. Drugs such as magnesium trisilicate will cause diarrhea, whereas aluminum hydroxide will cause constipation. Okay. Activity balance with rest. Will the patient have any problem here? Yes. Patient may have an altered sleep pattern at night related to pain and anxiety. Remember, we said duodenal ulcers will cause a patient to wake up at night in severe pain. Normal physical activity may also be impaired because of pain and anxiety. The patient has anxiety related to lack of understanding of all these factors. They don't know the diagnosis, they don't know the treatment plan, the prognosis, etc. So they will have anxiety. Lack of the balance may lead to debilitation. Lack of this balance between activity and rest will lead to debilitation. Patient will become weak and they'll have a poor outcome or prognosis. Sufficient intake of air. Patient has risk for ineffective tissue perfusion if ulcers resulting from hypovolemia. So please go through the problem analysis on each of these factors. The problems, these are the problems identified, and there are some nursing diagnoses that you can come up with if you are nursing a patient with a peptic ulcer. So here I have indicated a few for you. Acute pain related to caustic irritation or irritation due to acids, a chemical irritation of the gastric tissues evidenced by verbal reports, distraction behaviors, self-focus, and autonomic responses or changes in vital signs. There's also risk for imbalanced nutrition. There's risk for imbalanced nutrition greater than body requirement in duodenal ulcers, knowledge deficit. So take time to run through these nursing diagnoses. Deficient fluid volume may occur. This will be related to vascular losses, for example, from bleeding ulcers, evidenced by hypotension, tachycardia, delayed capillary refill, and changes in mentation and restlessness. Here is an example of a nursing care plan, just showing you one problem. Patient's problem is acute epigastric pain. The nursing diagnosis is acute epigastric pain related to caustic irritation or destruction of the gastric tissues, evidenced by verbal reports of pain, distraction behaviors, self-focus, and autonomic changes. The goal, patient will be relieved of pain, of acute pain. Okay, patient will be relieved of acute pain within an hour of admission. What are our interventions and rationales? Please add rationales to your notes. There should be rationales to every intervention. So administer prescribed medications, including antacids, H2 receptor blockers, or proton pump inhibitors to do what? To reduce gastric acidity. Advise the patient to avoid NSAIDs because these damage the mucosa. Give small frequent meals to prevent overdistension of the stomach, which may worsen pain. Your evaluation might be pain relieved within an hour of nursing interventions, evidenced by calm facial expressions and patient being able to rest comfortably. So take time to just run through the complications, then read about gastritis and dyspepsia, which are the other conditions affecting the stomach. This is where this particular recording ends. Thank you very much.